Hello, my dear doctors, right? Now I'll discuss a very important topic, right? That is called the pulmonary function test. Pulmonary function test can be used to determine whether a respiratory disease is obstructive or restrictive. The table below summarizes the main findings and give some example conditions. Like the obstructive lung disease and restrictive lung disease, like FEV1 significantly reduced, and on the restrictive lung disease, that is FEV1 reduced. Obstructive lung disease, that is FVC reduced or normal, or restrictive lung disease, FVC significantly reduced. So in obstructive lung disease, it is written that FEV1 percentage, FEV1 or FVC reduced, that is reduced, or FEV1 percentage means the FEV1 FVC ratios normal or increased. Obstructive lung disease are the asthma, COPD, and bronchiectasis, bronchiolitis, obliterans. And on the right hand side, there is restrictive lung disease. There is a pulmonary fibrosis, asbestosis, sarcoidosis, acute respiratory distress syndrome, as well as the infant respiratory distress syndrome, and also the kyphoscoliosis and neuromuscular junction disorders. And another topic that, along with that pulmonary function test, an important component, that is the transfer factor. Just follow me what is written, right? Once again, the transfer factor describes the rate at which the gas will diffuse from alveoli to the blood. Carbon monoxide is used to test the rate of diffusion. Results may be given as the total gas transfer, means the TLCO, or that corrected for lung volume, that called the transfer coefficient KCO. Causes of raised TLCO are the asthma, pulmonary hemorrhage, like the Wegener's, and as well as the Good-Pastor syndrome, and left to right cardiac shunt, polycythemia, and hyperkinetic stress, as well as the male gender and exercise. Causes of lower TLCO, that is the pulmonary fibrosis, pneumonia, pulmonary embolism, pulmonary edema, emphysema, anemia, and low cardiac output. KC also tends to increase with the age, all right? Some conditions may cause an increased KCO with a normal or reduced TLCO. Pneumonectomy, lobectomy, scoliosis, kyphosis, neuromuscular weakness, and ankylosis of costovertebral joints, that is ankylosing spondylitis, is costochondritis. So now, my dear, I would like to discuss the pulmonary function test. And that is very important in your exams, the data interpretations of the pulmonary function test that we need to go through so that we can reach our diagnosis. Which varieties of diseases by seeing the pulmonary function test. All right, let's start with the pulmonary function test, the boxes, all right. So we are writing the pulmonary function test. A little bit before going to the pulmonary function test, I'd like to give in box. All right, this box enters with the obstructive lung diseases, OLD, and restrictive lung diseases. Obstructive lung diseases are asthma, so you can write this is the mnemonics of the A for asthma. Yes, the B for bronchiectasis, all right, yes. B for bronchiectasis. And C stands for the COPD. And along with the bronchiectasis, another disease, that is bronchiolitis obliterans. So yes, the ABC, yes, the obstructive airway disease. And if you write the restrictive airway disease, once again, we can write the first disease in your notes. You'll see the restrictive lung disease are the pulmonary fibrosis. So we can write the PF, that will be helpful, pulmonary fibrosis. Yes, once again. And in a restrictive airway disease, of course, we'll discuss about the details of underlying etiology of pulmonary fibrosis and all the pulmonary fibrosis leading to restrictive lung disease. and this pulmonary fibrosis next to them, that we need to remember other pulmonary fibrotic-like disorders so that we can remember. Just write it down that ARDS, we are saying there is adult respiratory distress syndrome. Same thing in an infant, that is infant respiratory distress syndrome. So the same thing like the pulmonary fibrosis or interstitial disease like pictures, right? So this is a variety of restrictive airway disease. So what I'm saying, the restrictions, the lung tissues restrictions, and then other than the lung tissues, maybe the chest wall, we have the bones. So yes, the bony deformities, that is the kyphoscoliosis, right? You just write it down, the kyphoscoliosis. And any chest deformities as well, they will come up. And then also we have the muscles, so neuromuscular junction disorders. So these three groups, as well as these three groups, will be really helpful for obstructive lung disease and also the restrictive lung disease. Next, right, we'll discuss details about the, if you write the, what will the findings of OLD as well as the, what will the findings of RLD, all right? So let's do it, OLD and RLD. So let me start by the first group of features, right? The FEV1. Yes, FEV1 I'm writing. So mind you, listen very carefully. This is forced expiratory volume in first second. All right, what is that? Forced expiratory volume in first second. So forced expiratory volume in first second is nothing but, just write it down, this is nothing but the expiratory function of the lungs that we are detecting by doing this test. Forced expiratory volume, so E is there, so expiratory function. Another parameter that we do, that is FVC, means the forced vital capacity. Forced vital capacity we look, that is the inspiratory findings, means the inspiratory functions of the lungs. Forced vital capacity, vital means the inspiration. So that you can remember, this is the inspiratory function. Yes, forced vital capacity is nothing but the amount of, right, yeah, that you can inspire after full expiration. So the inspiratory amount, right, means the inspiratory function. Yes, the word the vital will give us the idea. Yes, the forced vital capacity, the inspiration. So as I said, the FEV1, E for expiration, and FVC, vital for inspiratory function. So these two important parameters of the pulmonary function test is the prime parameters that we can detect and can categorize whether it is obstructive lung disease or restrictive lung disease, all right? What is that? Whatever the expiratory, whatever the inspiratory means, expiratory means FEV1, inspiratory means the FVC, whatever the function, whatever the diseases like the obstructive and restrictive lung disease, of course, the both of these functions will be reduced in both cases, all right? I hope that you are getting me. Both will be reduced. But in an obstructive airway disease, what happens? In an obstruction, if there is an expiratory function is more reduced, instead of, in contrast, in restrictive lung disease, the restriction, so restriction means the inspiratory functions will be more and more reduced. Just make a start here, make a start here. So we can understand, in obstructive airway disease, we are getting FEV1 is greatly and significantly reduced. Means the expiratory function is interrupted and disturbed much more than that of inspiratory function in case of obstructive lung disease. In contrast to the restrictive lung disease, yes, the inspiration is a problem, expiration is a problem, but inspiration is a more problematic. Restriction, we can understand, right? Now what we do basically, the FEV1 and FBC ratio we do, all right? This ratio, or sometimes we call this is the FEV1 percentage, the same thing. Normally, this is 70 to 80% in a normal person, all right? So if you get the ratio, you see the FEV1 is greatly reduced and FBC is reduced. So these ratios will, in case of obstructive airway, less than 70%. In contrast, in restrictive lung disease, more than 80%, 70 to 80, yes. So in an obstruction, remember obstruction is less than 70%. In a restriction is more than 80%. Remember this one. If you can normal value, if I say the normal value is the 70 to 80, the current value is the 75. So yes, the normal value should be more equal 75, something like that. So we can normal. So yes, the 70 to 80% is normal. But if it's more than 80%, the restriction, less than 70% obstruction. Just remember this one. So we can put this is number 1, number 2 test, and this is the ratio, the most important test. Second group of test, we can write the number 3 and number 4. That is, we do the test of the residual volume and total lung capacity. Residual volume and total lung capacity. In an obstructive airway disease, because of expiratory function is interrupted more and more, so in each and every respiratory cycle, we have the amount of air that trapped in the lungs that is called the residual volume. So this residual volume is increasing, right? In an obstructive airway disease, is to the total lung capacity will be increased. In contrast, in a restrictive airway disease, that will be reduced, both residual volume and total lung capacity. Next bundle pack means the next test, means the 5 and 6. This is called the TLCO, that is total lung carbon monoxide transfer, means the gas transfer. Total lung gas transfer. And another test we do, that is KCO. Within the bracket, just write it down so that we can understand much more better. Milliliter per minute per kilopascal, the unit. So total lung gas exchange and gas transfer coefficient, K4 coefficient, whatever, the disease is obstruction and restriction. Both will be reduced. That is expected. Yes, that is expected. So now, this first, I'm saying this is the first bundle pack of the FEV1 and FBC. The second bundle pack is residual and total lung capacity. And TLCO and the case with the third bundle pack so that we can remember the test, the box, all right? That will be helpful, my dear. So yes. So we can remember all together. So once again, I'm saying FEV1 and FBC, both will be reduced in OLD and RLD. But FEV1 is reduced more in OLD. FBC, the inspiration, is reduced more in RLD. But the ratios is the normal 70 to 80%. So in case of OLD, it's less than 70%, but in RLD more than 80% ratio. Second group test, that is residual volume, has increased in obstructive and total lung cavity increased. In contrast, in RLD is reduced. And gas transfer is once again TLC and KCO, both will be reduced in both cases. All right. We'll discuss a little bit more about the KCO and total lung gas exchange. Means we call this is the TLCO is nothing but the transfer factor. All right. We are writing now the transfer factor, a box that will be helpful. What is that? That is TLCO, total lung gaseous exchange, will be increased. So what are the causes of TLCO is increased? Usually TLC is not reduced in both cases. So just write it down. The number one cause is the bronchial asthma. All right. Number two case is pulmonary hemorrhage. Then write it down the left to right shunt. And third cause is the polycythemia. Just write it down. All right. And the test that is TLCO is reduced, causes are, of course, all the disease means all OLD and RLD, no doubt, along with all OLD plus RLD, we already talked. And also plus some of the diseases, the TLCO is reduced, but they are not the obstructive lung disease and also the restrictive lung disease. What is that? And you need to write, yes, pneumonia. We'll get the TLCO is reduced. And also the pulmonary embolism, EM, pulmonary embolism, and also pulmonary edema, POE. So this is a bundle pack disease, and this is a bundle pack disease, also the anemia. We are writing here anemia. And we can write the low cardiac output. And we can write the high cardiac output here. A bundle pack, anemia, and this is the bundle pack. So then I can discuss more. So this is a box for the TLCO. And second box, I'm writing that we need basically, sometimes we are getting TLCO is reduced or normal, but KCO sometimes rather increased. So this is another box. So these are very separate causes that we need to remember. Just write it down. Number one, PT means pneumonectomy, LT means lobectomy, and number two, that is kyphoscoliosis. I'm writing KS, kyphoscoliosis, KS, just write it down. And another bundle pack is the neuromuscular junction disorders, just plus, write it down. And along with the kyphoscoliosis means the ankylosing spondylitis involving the costochondritis. This box, all right. So that I can discuss a little bit more, my dear. Yes. So look at the board once again. I'm starting, right, the box number 1. Yes, box number 1. So this is the obstructive lung disease and restrictive lung disease. Obstructive lung disease is A, B, and C. So A for asthma, B for bronchiectasis, B for bronchiolitis obliterans, and C for, yes, once again, COPD. And COPD includes, of course, the chronic bronchitis and emphysema. So this is the obstructive lung disease. Is nothing but A, B, C. All right, the box, small box. Next is the restrictive lung disease, means fibrosis, my dear. Must remember what I'm saying. Restrictive lung disease means pulmonary fibrosis. That's it. And pulmonary fibrotic-like lesions, these are ARDS or IRDS, means adult respiratory distress syndrome or infant respiratory distress syndrome. And second box is the restrictions, the chest wall restrictions. Sometimes the costochondritis, sometimes the kyphoscoliosis, right on the back, and sometimes, yes, the neuromuscular junction disorders. So restrictions. So the summary talk, the obstructive lung disease, the ABC, asthma, bronchiectasis, bronchiolitis obliterans, and C for COPD. And restrictive lung disease, the fibrosis, ARDS, IRDS. And also, once again, the restriction of the chest wall means the chest wall deformity disorder, means the costochondritis, sometimes the pactus chest also, means the pactus excavatum, pactus carinatum, pactus chest also, all right? And also in the back, kyphoscoliosis, and also the neuromuscular junction, bones, and also the nerves and muscles junction disorders. These are the chest wall restriction. So these are the restrictive area disease. We got it, the idea. Second box, yes. What the pulmonary function test revealed in the different diseases, all right? So we got a different, right, the two diseases together. The second bundle, this one, and third bundle, this one. All right. So what is that? The first bundle, you see the FEV1 and FBB1, FBC ratio less than 70% and more than 80%, must remember. So if you can remember, 70 to 80 is the normal, so less than 70 is obstructive, more than 80 is a restrictive airway disease, means the restrictive lung disease. And residual volume and TLC will be increased in contrast to the RLD that will be reduced. And of course, TLC and KC will be reduced in both cases. But there is an exceptional boxes, my dear. We know the TLCO, just forget this box, right? Third box is the most important, but TLC, of course, all OLD and RLDs, all causes of OLD, yes, and all causes of RLD, we talk about the TLC should be reduced. We talked about TLC reduced. And other than OLD and RLD, some of the diseases, of course, we are getting the TLC and total lung gas transfer should be reduced. These are pneumonia, pulmonary embolism, and pulmonary edema. So the P group of diseases, yes, pneumonia, pulmonary embolism, as well as the pulmonary edema. Say pneumonia, pulmonary embolism, pulmonary edema. And also some of the disease that the TLCO gas will be reduced, gas transfer will be reduced if there is an anemia, mind you. Of course, if the blood is less, so definitely the gas transfer will be reduced. And you see the low cardiac output. So in these both cases, of course, the TLCO should be reduced. So first, second, and third bundle back of the TLCO reduced. TLC reduced, of course, all OLD and RLD. Second bundle pack is, yes, the pneumonia. Yes. Next, the pulmonary edema, then pulmonary embolism. Must remember. And third talk is the anemia, less blood and less cardiac output also reduce the TLCO. But in contrast, you see some of them, we are getting the TLCO is increased. In contrast to low cardiac output is a high cardiac output that will be increased. In contrast to the anemia, that polycythemia, of course, TLCO anemia, less blood causing less TLCO, so high blood means the hemoglobin causing this polycythemia causing raised TLCO. So the same thing, if you feel this bundle pack is nothing but polycythemia bundle pack, what is that? Left to right shunt. Left to right shunt means the left blood passing to the right, and this right-sided blood, more and more blood passing through the lungs. So once again, passing through the lungs means the TLCO should be reduced. And pulmonary hemorrhage is something like the alveoli having hemorrhage. So here's more and more blood. So polycythemia means more and more blood. Increase the TLCO. Now talk about the asthma. All right, asthma. In a bronchial asthma, we think, right, the TLCO, the gaseous exchange is increased. Gaseous exchange is increased in bronchial asthma in TLCO. So essentially, whenever the TLCO is reduced, so KCO should be reduced, no doubt about it. But, this is very important. So TLCO increased means we think that KCO increased. Whenever TLCO is reduced, we expect that the KCO should be reduced. But some of the diseases, you see, the TLCO, the last box, right, number 4, this is the number 5 box. You see, the TLCO is reduced or normal sometimes. TLCO reduced or normal. But KCO is increased. This is important, all right? TLCO reduced or normal. TLCO normal or reduced means gaseous exchange is reduced, but the KCO is increased. KCO is increased in pneumonectomy and lobectomy, and also the kyphoscoliosis and ankylosing spondylitis leading to costochondritis and neuromuscular junction. These are chest wall restrictions and pneumonectomy and lobectomy. What happened actually? Basically, in these cases, KCO increased. KCO means, just see, this is milliliter per minute per kilopascal. Forget the kilopascal. Milliliter per minute means the speed of gaseous actions. Speed of gaseous actions will be increased in pneumonectomy and lobectomy. Feel that the one lung is absent, another lung. Only single lung that you have. So for compensation, the KCO, the rate will be increased. Rate increase means the KCO increased, but total lung gaseous actions will be reduced because one lung is absent. So that's why you see the TLCO is reduced or normal, but the KCO is increased. Same thing in lobectomy. Same thing happening in the chest wall deformities, means the chest wall diseases. Chest wall diseases like the neuromuscular junction disorder, kyphoscoliosis, and costochondritis by the ankylosing spondylitis. I hope that, this the last box is the most important box among all these pulmonary function tests. So once again, I'd like to summarize the first box, that OLD diseases are A, B, C, and RLD diseases are nothing but the fibrosis. Lung fibrosis, and outside the lung restriction in the chest wall. Chest wall diseases means the bones as well as the neuromuscular junction. Then OLD and RLD, the single talk that FEV1 and BC ratio less than 70 is the OLD, more than 80 is an RLD. And residual volume and TLC is increased in OLD but reduced in RLD. In contrast, TLC and KCO is reduced, both cases reduced. So the same thing, TLCO reduced and KCO is reduced, of course, all OLD and RLD. A bundle pack of some of the other diseases other than OLD and RLD, the P diseases means the pneumonia, pulmonary edema, pulmonary infarctions means the embolism. And also the low cardiac output, of course, the low KCO and TLCO, and anemia, as well as the low blood means the low TLCO. In contrast, you see the low cardiac output, high cardiac output, increased KCO and LCO. Anemia, high blood means the polycythemia, left to right shunt, and pulmonary hemorrhage. We need to know all together. A single disease might, this is very important, asthma, even though this is an obstructive lung disease, but this is increased TLCO and KCO. Just remember, even though this is an asthma is an obstructive disease, the TLCO and KCO is increased. Remember? Next, last box, TLCO is reduced to normal, but KCO is increased. Some of the diseases and some of the conditions. Of course, pneumonectomy, yes, KCO is increased, but TLCO reduced to normal. In neuromuscular junction disorder, kyphoscoliosis, as well as the costochondritis, in that case, of course, you see, this is very important. In that cases, also the TLCO can be normal or maybe reduced, but yes, increased KCO because of the rate is increased, compensatory rate. That's it. The last I like to give an example so that, right, if you write FeV1 is 2 liter and MBC is 4 liter, and it is written that residual volume is reduced, TLC is reduced, and KCO increased, TLCO is increased. So this is the data interpretation sometimes in your exam. My dear, whenever this data, you should do the first bundle pack work. So 2/4 means FeV1 FBC ratio. You see the 2/4 equal to 50%. It does mean this is OLD. You see the residual volume and TLC. All right, just make it high. Residual volume and TLC, make it high. So this is, of course, the OLD. This is proved. And in KCO and TLCO is increased. OLD plus KCO and TLCO is increased. All right. So I'm writing here so you can understand. Make a box. Just OLD plus raise TLCO or KCO. Diagnosis. Everybody can understand. Obstructive lung disease, you see the asthma, bronchiectasis, bronchiolitis obliterans, and COPD. Among them all diseases, TLCO and KCO is reduced, but only the disease, the asthma, where the TLCO and KCO is increased. So OLD with the raised TLCO and KCO. Remember, this box is a tremendous important box, my dear. That is bronchial asthma. Once again, if you write the OLD plus reduced TLCO or reduced KCO, so other diseases means we can write that is ABC other than bronchial asthma. Just write it down, right? The asthma, all right, means the bronchiolitis obliterans, bronchiectasis, and C for COPD. Another box we can write this RLD based on FeV1 FBC ratios and also the residual volume and TLC. Reduced TLCO or reduced KCO, whatever, is nothing but pulmonary fibrosis. We can write. Yes, you see the pulmonary fibrosis. But if it is written, my dear, this is very important, RLD plus raised once again KCO but reduced TLCO. This is important. You see the restrictive diseases, RLD with raised KCO but reduced TLCO. The second bundle pack means kyphoscoliosis plus maybe neuromuscular junction disorder, maybe costochondritis. So this box. So these are the boxes of examples of summary box 1, 2, 3, and 4. That will be helpful, my dear. Just write it down and do practice. Then mold them together. You'll be expert on pulmonary function test. I hope that My dear, you enjoyed this pulmonary function test and it will be really, really helpful. So thank you very much.